Okay, welcome, Dr. Wright. For those of you who aren't familiar with Dr. Wright, I met him in 2017 at the International Benzodiazepine Symposium. And after that, he and some other physicians, researchers, people who attended there started a nonprofit called the Alliance for Benzodiazepine Best Practices, or you can find it at benzoreform.org. So welcome, Dr. Wright.
Thank you. Great to be here.
Yeah, thanks for doing this interview. Really appreciate it. I'm really excited for members of the community to see you and hear what you have to say. So do you kind of want to just tell us how you got into this whole world of benzodiazepines?
Certainly. And first of all, it's really unfortunate we have to be here,
Yeah.
after all these years. But, I have to say, I was part of the problem and now trying to rectify all that. But back in the day, I did my training, it was medical school at the end of the 1970s, residency in the 1980s. And for those of us in practice, and it was family medicine at that particular time, it was just sort of like old hat, benzodiazepines were the so-called, quote, minor tranquilizers. And so it sort of diminished the importance of, worried about adverse events and how to deal with that and things like that. So we became quite accustomed to writing these quite liberally for individuals with all sorts of problems. And of course, it's primarily in the anxiety domain, but used it in a variety of other ways as well. And so going along, of course, I had a number of patients, many patients over many years using these. And then from time to time, patients would come in and really highlight their concerns. And it really puzzled me. I started
Like what kinds of concerns were they, bringing up?
Well, side effects, and or they thought there were side effects, and looking back, I would have to agree with that. It looked like from time to time that anxiety was accelerating. Didn't recognize it at that time that it could be related to the benzodiazepines in and of themselves, and so I would increase the dose. Mm-hmm. Or there would be side effects that I totally discounted as being related to benzodiazepines because they were odd.
Right.
Ringing of the ears, hypersensitivity, vision, smell, all those kind of things. And I said, well, it's got to be something entirely different going on. And then I would travel down that particular road, treating those conditions in other ways, and not recognizing the association with benzos.
Right. One of the, like the very first things that I heard come out of your mouth is you stood up on the opening day of the International Benzodiazepine Conference and you said, "Hi, I'm Dr. Wright and I'm a recovering benzodiazepine prescriber." And I just loved that. I was like, okay, this guy gets it. Thank you. Because, I had spent, years dealing with doctors who just hadn't even considered that their prescribing of these drugs was, causing problems.
Well, when I started looking at this, and it's been about 3 years now, taking a look at this, and you say, hey, why don't you take a look at this? It might be other than what you expected. And I said, yeah. And I started to look at that and started to recognize slowly over time, because I'm sort of an evidence-based person. I like to see the research in relation to that. And taking a look at the literature sometimes isn't really helpful to see what's really going on out there, because I've gone through everything that I could find in terms of benzodiazepine efficacy. And frankly, these researchers really were not identifying the problems, just like I wasn't either. And I think that had something to do with the peculiar nature of some of the side effects, and certainly with withdrawal reactions, and the ready willingness of us as prescribers to attribute a variety of symptoms to something else. So there's this area of medicine called psychosomatics.
Right. Yeah. Where I think a lot of us are familiar with that word because
Right. And a
quite a few
lot of survivors are going to run into that particular term.
times.
Very easy for us to discount a variety of things that are seen in that look like that because they're peculiar, and we haven't yet defined in the neurochemical, neurophysiologic way that there's a relationship there. It's morphed into somatoform disorder in DSM-4, and now somatic symptom disorder in DSM-5. And so it's no longer intended to imply it's all in your head.
Mm-hmm.
You have significant symptoms that are connected that are quite disabling. So it's still possible to use that terminology, but frankly, for those of us in primary care and otherwise, it's far, far too easy to simply attribute away from what I think is actual benzodiazepine injury to another cause or medically undefined illness is kind of a category that we look at in that regard, which means basically we don't yet understand it. But we're starting to, I think, with the kind of work we're doing.
Why is it, do you think, that doctors don't tend to look at the medication as the source of the problem? Why is that not one of the, I guess, main factors that they would consider in dealing with a patient who's presenting with new or worsening symptoms?
Well, probably a couple of reasons. First of all, a lot of times it's the primary condition for which the medication is being used that seems to be connected, now that we look back on it, to the medication itself. And it's really only recently that we identified opioids in that regard. Opioid-induced hyperalgesia, where the opioid's supposed to get rid of pain, actually can create a situation where the pain is amplified. So that's actually fairly new. And so our ability to identify that in other medications is lagging even behind there. And nonetheless, I do think that there is a benzodiazepine-induced hyperangiogenesis. It's just not been identified in the literature, and we have not really outlined some potential neuropharmacology associated with that.
So is that your goal? Can you tell us a little bit about how and why you got this nonprofit started, and yeah, what are your goals with that as far as helping people in the benzo community?
Sure. So the nonprofit was started basically generated through the International Benzodiazepine Symposium in Bend, Oregon, about a year and a half ago. And there, Bernie Silvernail tapped me out and said, hey, we need to build this into something bigger. Because looking back, you can see a variety of efforts that had fizzled out in terms of making a difference.
Yeah, and just so people know, Bernie Silvernail is actually the spouse of a benzo survivor. So he was very passionate about this. He's a businessman. He's not like a physician, but he really was really motivated to do something, especially at this conference, I think. And also you worked kind of arm in arm with another benzo survivor, Marjorie Carmen, who was really the one who kind of got all this going and reached out to you to kind of,
she was the one who reached out to me originally. And, you know, thank goodness for her. I mean, she put this whole thing together and put together the economics and the ability for us to do that. And so those two individuals in particular, and yourself, Jocelyn, as well, have really developed a level of sophistication about what's going on here in a very deep way, in a way that's deeper than the vast, vast majority of us that are prescribing this medication out there. And so the Alliance now put together in order to really focus on the prescribers themselves. Now, there are a variety of groups out there for benzodiazepine survivors, but I'm not aware of something that is out there that focuses on the prescriber. Now,
Right.
we
Well, like you said, I mean, most of the work that's been done in the past has the brunt of it, the labor has been done by patients, you know.
have,
So I think the thing that's exciting about this is actually something it's doctor led. It's not necessarily patient led, which is really great.
right, and so we've got a learning curve, and I certainly have as well. And even since the International Symposium, I've been learning quite a bit and learning a lot about what I don't know. And actually, I think there's a lot that all of us don't know
Oh
uh,
yeah.
yet to sort out. And so, not that we're bumbling along, but we're trying to very in a very scientific way establish the kinds of things that actually work, the kind of things that actually have not worked in the past. And so the website focused on prescribers also has areas for survivors and patients and families as well, but primarily focused on prescribers to give generalized guidance as to what's going on, how to identify the problem, and then what to do about it. That is our primary focus.
If there is any one thing that you could say to any physicians who are watching this right now, what is the main point that you would try to impress on them?
Benzodiazepines are a bigger deal than we ever gave credit for in the past. And because of that, because of the severity and unknown frequency of the severe side effects, as well as what happens in the withdrawal area, uh, and finally, because of loss of efficacy that appears to occur after taking them for a while, benzodiazepines should not be initiated as liberally as we have. And I think of it in this particular way. There are circumstances where benzodiazepines are valuable. For example, alcohol withdrawal,
Mm.
it's absolutely very important. Certain conditions for anesthesia, occasionally for crisis anxiety, and then in the circumstance where seizures just don't stop, where that's called status epilepticus. Aside from that, though, benzodiazepines, when used, if used, should be not necessarily first or second line, but should be third line in the sense that if the severity of the anxiety condition is bad enough that an individual is functionally impaired, that may be important in that circumstance in order to bridge the individual until other therapies get going. Because the other therapies take time. Probably the quickest other therapy is pregabalin or Lyrica. It has its own set of problems that we can discuss too. But cognitive behavioral therapy, these take a while to get started and get going. So we think that limiting initiation to individuals that are severely and functionally affected and limiting the duration is particularly important. And for individuals that are on benzodiazepines for more than 4 weeks, the offer to taper and discontinue should be fairly universal. I'll never say never, but it's probably a very small minority of individuals for whom no other suitable alternatives exist. But we do know now, based on some of the studies and relook at some of the old studies, including Heather Ashton's study in 1987 of 50 individuals requesting tapering, that the anxiety that is present while while one is on benzodiazepines may actually be generated by the benzodiazepines. It
Right.
was interesting. In that particular study, there were 50 individuals, and 10 of them, basically 20%, developed agoraphobia, so that fear of being out and
I mean,
around,
I did. I
while
developed
they were on
agoraphobia.
benzodiazepines.
Yeah.
Who would have figured that, and that diminished and went away when the benzodiazepines went away. And so that and the severity of the withdrawal that occurs certainly in a subset of individuals, can't quite tell what that frequency is. It may be 15, 20, even 30%, depending on how you look at what severity means. Because of that severity, limit initiation, limit the duration, offer tapering to all individuals that are on it for more than 4 weeks, and do the tapering process in a very safe, progressive, incremental way in order to make it most likely to be successful.
Yeah, and I know a lot of what you pass on to the doctors that you present to, you're a real stickler about it being very evidence-based, research-based. But you know, from my personal experience, and I know the experience of a lot of people out there, I would say that even before 4 weeks, I think there are people who are on it less than 4 weeks, and they develop this syndrome or this injury or whatever we want to call this. I was definitely one of those people. And it's important that I think we also are let people know that we're not just talking about like strictly benzodiazepines at Benzo Reform. By the way, if people don't know, I'm an advisor there. I'm like in an advisory capacity, but we use the term BZRAs, right? Which is benzodiazepine receptor agonist. Is that right?
That's correct. And
Yeah.
so there are a variety of agents there, although the benzos are primarily the ones there. We have the Zdrugs, which are used for sleep as well. Phenobarbital, which is rarely used at this time, is in that category. Secobarbital is out there. Butalbital, however, is much more frequently used for headaches and should not be used in that context.
So those are generally known as like barbiturates.
Those are barbiturates, right. And then we have the old, we have some of the old drugs that just are hardly around, although carisoprodol, which is Soma, kind of plays into this as well. But the primary agents are really the benzodiazepines and the Zdrugs here.
Right. I mean, because for me, it was a Zdrug. It was Ambien.
Sure.
And I was on that for, you know, less than a week when I cold turkeyed and had the reaction that I had, which of course, you know, was misdiagnosed. And then as a bridge, kind of like you were mentioning before, actually, as a like short-term bridge while they put me on an antidepressant, I was given a benzodiazepine, which of course I couldn't just suddenly stop after 4 weeks of use because I already had this problem and didn't realize that I needed to do a taper. When you talk to doctors about tapering somebody off, what advice do you give as far as helping patients to taper off?
I think slow and steady is the way to go. I mean, there's a lot of different ways to do this. You can remain on the original benzodiazepine and taper, but I think that it's more likely to be successful if you transition to a long-acting benzodiazepine receptor agonist. And the ones that are out there actually are phenobarbital and diazepam and clonazepam. Diazepam, if you can tolerate it, has greater utility in that regard because you can do smaller dose reductions successfully. Clonazepam, where a typical dose is 1 milligram, it's hard to go down 5%. But with diazepam, you can certainly do that. There's a solution out there, 2 milligrams per 1 cc, that allow dose reductions that are much smaller. So transition to a longer acting agent, and then having a overall plan that looks at this may take 18 months or even longer, rather than 10% per week or 25% per month, which is what we've seen out there. Now, there are a number of individuals that can be quite successful with those rapid reductions. It's just that we don't know who is going to be successful. And so at the front end of this, I really recommend making a very small reduction for the first step, see how that goes. If there's sort of like very little difficulty whatsoever, I'd say 1 milligram of diazepam, you can double that. And then kind of walk your way on down. And if it's clear that this is an easy situation, you can enlarge the dose size and making those reductions as you go along. But I wouldn't do it at the front end. And a couple reasons for that. One is, A, too rapid a reduction can really be catastrophic. And B, as a prescriber, you want to maintain the therapeutic alliance. Patients, of course, are worried that I'm going to throw them under the bus. And
Yeah, well, that's a real concern. I mean,
yeah,
because that's something I see
it
all
really
the time.
happens.
Yeah, it does, because, and it's interesting to me to see that dynamic, because if somebody were put on, say, Lexapro or Celexa or something like that for anxiety, and they go in and they say, I want to get off this drug, generally the doctor will be like, okay, well, taper, and it's kind of up to the patient, as to how they want to get off the drug. But if somebody's on a benzodiazepine for the exact same reason, for anxiety, and they say, I want to get off this drug, the doctor says, oh, okay, well, I'm only going to give you 4 weeks. And then, so it's like, I'm going to cut you off, because all of a sudden now I'm not treating you for anxiety, I'm treating you for addiction. Even though that person was never diagnosed with that, has never abused the drug, it's suddenly this shift happens simply because they have a desire to get off their benzodiazepine.
Yes. So I've done addiction medicine for now 31 years, and benzodiazepines, certainly it's possible to be addicted.
Mm-hmm.
I've only seen one patient that I am absolutely convinced was addicted to benzodiazepines. The vast majority of individuals that have challenges here are not addicted, but they are challenged for other reasons. And the other reasons are there are side effects, and it's hard to get off, and the medical provider, like me, has a limited skill set in being able to assist in that process. We very quickly make the assumption that it has something to do with addiction when somebody makes a request. We are aware with the literature that individuals that feel that they are addicted to something, there's an increased risk that they actually are. And so, you have to understand the mindset of the prescriber in that regard. That's what we're taught. And so, but as it turns out, when you're looking at benzodiazepines, that's hardly ever the case. So the definition of addiction is compulsion, thinking about it all day long. Mm-hmm. Certainly that would be the case with benzodiazepine survivors.
Yeah, if you're intolerant, and you're always having horrible symptoms, that could be.
And, loss of control, where I plan to take 2 today and then I actually take 20. We don't see that. And then continuation in spite of adverse consequences. Now, within all of that, you actually have to look at the reasons behind that, because it's actually is craving in addiction that drives those 3 elements. So, I want this for non-medical reasons. And that actually doesn't happen with the vast majority of individuals that are using benzodiazepines. They're not craving an elevated use of these substances. They have not found a prescriber to help them, or they have not been able to identify a pathway to discontinue the successful. That's why they feel stuck, not because of the craving element. So this is not addiction, but to jump quickly to that addiction assumption is what a lot of us do. And then for a lot of us too, we want to rapidly get rid of the medication, because we do know if it is true addiction, individuals can't maintain the same dose. And a tapering schedule typically does not work, because if I say for an opioid, if I give them 10 days worth, an individual who has the disease of opioid use disorder, if I give 10 days and say, spread this out over 30 days, they're going to take it in 5 days.
Yeah, right.
That's what happens with addiction, but that's not what's happening here.
And I think, a big part of the problem is that patients aren't educated in the difference between dependence and addiction. I myself went into my doctor, and I was really lucky to have a really good doctor who had known me a long time. And I said, look, I keep trying to taper off this thing. I can't get off. I'm addicted. And he said, you're not an addict. You're dependent. There's a difference. And so I was really lucky, because I could have gone down an even worse path and trying to get off this. But even then, his recommendation of me cutting my pill by a quarter every week was far too rapid for me, and with my condition. And unfortunately, even though he was really great and understanding, he just did not have the knowledge as to how to really help me.
Right. So the starting point is really to understand this is not addiction. And then the secondary part is how do you do this? And so dependence. I think it's really important to talk that through a little bit. I'm dependent on oxygen. If you take that, don't do
Right.
very well. I might be dependent on a beta blocker for my blood pressure. If I take that away, my blood pressure goes up. That's different.
Mm-hmm.
It's the compulsion, loss of control, continuation in spite of adverse consequences, which is fed by the craving that defines addiction. So I think it's really important for prescribers to step away from making the assumption that addiction is present all the time. It does occur, but it's very rare. When individuals use benzodiazepines non-medically, they are usually using them to amplify the effects of other substances that they actually are addicted to.
Right.
They're not addicted to benzos. They're just pumping up the effect of alcohol, or they're kind of, taking the top off of the stimulant high, or they're dealing with the withdrawal from alcohol. And that's different. It's not a good use of the medication, but nonetheless, it's not addiction to benzodiazepines either.
Not truly. So is this what you discuss when you present to physicians at these conferences? And, I'm kind of remiss. I'm not a professional interviewer, so I didn't do this at the beginning, but can you just tell us a little bit about your expertise? Basically, why should other doctors listen to you regarding this subject, what your background is, and then kind of what it is that you do present, or that it's not just you. Obviously, you have other fellow physicians who present with you, but kind of give us the general message that you do present when you go to these conferences.
Sure. So I grew up in family medicine, started doing addiction medicine 31 years ago, and then medical pain management about 15 years ago. And so, of course, in this domain, we worry about addiction-prone substances in general. And benzodiazepines are in that category, but what we know about that at this particular time is benzodiazepines are really rarely associated with addiction. But we make assumptions because that's where our training was, that if it's addiction prone and there's trouble, there ought to be, there's got to be addiction to benzodiazepines, which was totally inaccurate. What we have found is that the side effects to benzodiazepines can build up over time. Mm-hmm. We think that there is hypersensitization. There is an array of peculiar side effects that can occur, and there's a very challenging part in withdrawal, which is very confusing to us as prescribers. So, for example, the pattern for most addiction-prone substances is that I stop the substance and very slowly over a period of time, the withdrawal symptoms disappear. Now, that can occur with benzodiazepines, and it does occur for a subset of individuals. Mm-hmm. We also see a pattern where the symptoms go down and then back up. And there can be a situation where they don't go down, but they persist at a very significant level. Mm-hmm. And all of these patterns can be overlain by a pattern of waxing and waning of these symptoms as well, sometimes spiking within minutes to hours, lasting for an indeterminate period of time. Because of those peculiar patterns, we tend to attribute it to something else, but not so fast. I think it's really important to recognize that those patterns can well be the result of injury from benzodiazepines, which indeed looks like to me can be indefinite for a subset of individuals that are involved, but tends to improve over a period of time. What that means is these small reductions are really important, with each step along the way, as much as possible, making subsequent reductions, even if you can't make them every month, because I think the neuro readaptation takes a while. It may be every 4 months before I can make a subsequent reduction for an individual, maybe even longer. But I think it's really important that the intensity of the withdrawal at least diminish a little bit of a pause before making that next reduction, because it's the continuous withdrawal that's a particular challenge. In the middle of all this, we also don't want to add back in benzodiazepines or use as needed benzodiazepines because of this neurophysiologic situation called kindling, which means that the on-off of benzodiazepines can actually hypersensitize the GABA receptor in such a way that it's much more difficult. If I bump back up or use as needed, it's harder then to come back down after this hypersensitization event. And I do think this hypersensitization event probably has a play into causing anxiety and causing certain pain conditions. These are unexplored as yet in the evidence-based research, but we're looking at that.
So by looking at that, do you mean that your plan is to do research into this, what's actually going on with people's bodies? Because it seems to me a lot of it right now is we kind of have this theory about GABA receptors, but we don't really know exactly why people are so bad, why some are so bad, why some aren't, why some can just cold turkey and be fine, and others are on a super low dose for a few weeks and spend 2 years tapering off. So what's your goal with that?
We're looking at that. We're actually looking at a couple of animal research projects right at this time. And the focus there is actually on the peripheral benzodiazepine receptors. These were discovered first, as best I can tell, in about 1992.
So you're talking about receptors that aren't like on the GABA neuron or on the GABA receptor?
They're not GABA receptors. They're actually entirely different. They're called translocator protein. They're outside of the central nervous system.
So they're just kind of everywhere throughout your body.
They are everywhere. And because they're everywhere, that can explain some of the peculiar symptoms as well. And so it's important to do this to get validation that there is really true benzodiazepine nervous system injury going on, because in our minds as prescribers, we want to have that neurophysiologic explanation to say, this is not a somatic symptom disorder, where the individuals are off a notch.
And I think as patients, we want that too. We want a diagnosis.
That's right. In a lot of individuals that are survivors, and they've told me, and they say, I feel like I'm crazy. And, somehow I'm the one that's off a notch, just like my prescribers implies, the rolling of the eyes and the glazed over look that occurs. Once the conversation heads in a certain direction and you've lost your prescriber in that process in terms of understanding or connecting with the reality of what's really going on. So animal studies, certainly. And then I think it's going to be important to elevate what is hidden in plain sight. As I go through the literature of the original researchers, even in more recent stuff, what I find is the kind of concerns that I see in the online communities and expressed very clearly as an association with benzodiazepines is not evident in the literature. So I think it's really important to show this for what it is, so that individuals that are prescribers can understand it's real, and it's certainly potentially what's going on for the person who's sitting in front of me and is concerned about whatever they're concerned about in relation to benzodiazepines.
Yeah, and one of the things that I really love about the presentations that you guys are doing is well, I guess my job in it, which is to put together these patient panels, because the science is important and obviously the facts are important, but I feel that what really is sort of that really sort of hits at home is having these real life stories that bringing a human perspective to this. And I don't know what was it that really inspired you to do this, but I know that I have had a couple of people from the conference who came up and they told me, it was your story or it was your questions and your concerns that really inspired me to join Benzo Reform or the Alliance and work on this, because they just had no idea how really bad benzo withdrawal syndrome could be for people until they heard from their own lips, you know?
It absolutely changed my life. If you take a look at the literature, you kind of think, oh, yeah, this is kind of what I thought was going on all these years.
Mm-hmm.
But then when you sit with individuals and their stories, the evidence research is important, but the stories are too. I mean, when you think about it, how does science really progress? Well, usually it's not like we have a thought out situation where it said, oh, this category called benzodiazepines ought to work for this. But you stumble onto something serendipitously. And so Leo Sternbach actually did stumble onto chlorodiazepine epoxide as maybe having anxiety benefit. And so, for example, we had a blood pressure medicine called minoxidil out there, and it had a lot of side effects. But one of the side effects was it grew hair. Nobody knew that, and now it's used for growing hair. So we stumble onto something, and then after the fact, figure out how it works. And that's kind of where we are right now. The stories are so very important because the depth and severity of this was not something that I had recognized. And I had thought, well, perhaps these individuals have other psychiatric concerns going on, but the frequency of it and the relationship that was clearly drawn to use characteristics of benzodiazepines really caught my attention at the International Symposium, and that's what got me going in particular. It really was the stories, and now we need to figure out a way to explain the stories neurophysiologically and a better avenue to help individuals that are so severely affected and need help.
And so along with the research, one of the projects that we are working on is an updated withdrawal manual. So that, because that was basically written back in the late 80s, if I'm correct. And we've learned a lot since then, mostly from trial and error, I think.
Heather Ashton, it was a brilliant piece of work. And I think it was originally, built out through the 80s, but I think published in 2002 with even an update in 2011. Mm-hmm. But there are dated elements to that, but it's just amazing to me that the threads that she has in there, like the windows and waves and all those kind of things, they still ring true in that regard. But there is updating, and we're looking at putting together this workbook that fills in some of those holes and maybe provides some even better guidance for how to get through this, how to speak with your medical provider, how to become successful in moving off benzodiazepines when that's necessary, and that's virtually always necessary.
And my hope too is that this will be, more widely recognized within the medical community, because while, of course, the Ashton Manual is the Bible for people within sort of the online support communities and, is our really what we base everything on, you're very hard pressed to find a medical provider out there who has heard of the Ashton Manual or read it. And so, you have patients who will take it to their doctors and, they may or may not take a look at it. So my hope is that because we've got this nonprofit and this entity established that is very physician-based, that this will be something that will be more recognized as you go and present it, across the United States as you're already starting to do, so that it won't be necessarily so incumbent upon the patients to educate their physicians about withdrawal methods and successful tapering.
To be fair, I run into a couple providers who are familiar with it, but usually they're familiar with it at a distance and not aware of the contents. And the contents are valuable for prescribers, not just those individuals that are affected by it. One of the challenges with the studies that Heather Ashton did was they were all very good as far as they went, but they were not prospective, controlled studies in the way that we now understand them. But frankly, so were that kind of critique can also be applied, especially to the efficacy studies for alprazolam and clonazepam and those kind of medications as well. We tend to gloss that over.
Yeah.
So I think it'd be useful to kind of look at revisiting all that. Now, that costs a fortune to redo all those studies. So I think that the better strategy probably is to show the adverse outcomes that are already out there and say, let's look at this again. Let's, be attentive to and truly listen to the individuals that are affected by this, and not be so quick to discount this as another psychological condition that maybe have been developing and unrelated to benzodiazepines. That's what we hope to do. And we hope to end up in front of the FDA in about 2 to 3 years after we establish a foundation, animal research, human research, and engaging a variety of partners out there. We want to end up at the FDA and look at the possibility with them, or encourage them to change the black box, add information to the medication guide, which is the informed consent agreement that is supposedly there, to look at rescheduling, and then a thing called REMS, which is risk evaluation mitigation strategies. In 2008, there was a law that was passed that allowed the FDA to add on top of the prescribing information document that there are certain educational requirements by pharmaceutical industry of prescribers about certain medications that are higher risk, like the opioids.
So they would have to basically pay for to put out money there, basically, to educate prescribers about things that weren't necessarily originally included in the education of their
That's correct. That's correct. And we think that that is a mechanism that will amplify the message out there in ways that we as a smaller organization really can't do. We want to get to the vast majority of the prescribers in that kind of a way. We want to alert them that there's a big deal out there, and we want to back that up with educational pieces. But it's a relatively small group of us that are involved with this, and we're looking at ways to amplify the message.
Yeah, and while we are starting off kind of small here, I know you guys are savvy and you know ways of getting the research funded and things like that. But I just want to let people know, if anybody does want to support this, if you want to get involved, if you're interested in the work that's going on, go to benzoreform.org. You can donate, you can share it with your doctor. Let them know. There's a lot of great information. I know Dr. Wright helped to develop a lot of the content, and he's very much a stickler about making sure that he's got every word exactly right, so nobody can kind of catch him on anything there. It's all correct. If you want your doctor to read something and it's legit, go to Benzo Reform, because that's where you're going to find it.
I don't know if it's all correct. We've got a lot to learn yet, but we're looking at revising everything as we learn along the way.
Well, yeah, I mean, with the knowledge we have now, I think this is as good as it can get. So yeah, just to kind of sum up, was there anything else that you wanted to let my viewers know, many of which are benzo people themselves or loved ones who are trying to support people going through this? I think they're interested in just hearing, what a doctor has to say to them.
Well, I think it's really important to understand that there are a number of us out there ready, willing, and actively engaged in making a change out here. It is not desperately hopeless, although it certainly feels that way, I'm sure, to a number of individuals. For the prescribers out there, I think it's really important to understand, and for you, for individuals that are using benzodiazepines or thinking about them as options, limit initiation, limit duration, offer tapering to individuals more than 4 weeks, and do a tapering process that is slower than you think you need to do, with adjunctive assistance, sometimes with medications, but more often than not, cognitive behavioral therapy, in order to assist these individuals along the way. So it's a two-part message, both for the prescribers and for the individuals that are currently suffering. And finally,
Yes.
For all the benzodiazepine survivors out there, I'm sorry. You know, I really was certainly part of the problem inadvertently. And, you know, it really distresses me to look back on all this, but what can we do at this point but to go forward and correct these problems that all of us, many of us, were involved with over the years?
Thank you. I think that will mean a lot to the people who are watching this. So thank you.
I really mean that.
Well, thank you, Dr. Wright, for taking the time to do this, and I'm sure we'll do this again. I'm sure I'm going to get a lot of questions from people, or we'll kind of know where to take this next time. But it's been a real pleasure to work with you on this.
Likewise. Looking
Yeah,
forward to working with you more.
yeah, me too. All right. Well, we'll chat later.